Hello, everyone. Welcome. I'm Jerry Dorman, the Senior Adult Director at the Mirage JCC. And today we have a special guest, Dr. John Micah, and he is going to do one of our Healthy Life series. Oh, I have more people in the waiting room. I'm just going to get them in. And there we go. And so he is going to impart us with some great information. And I wanted to tell you just a little bit about him, and then he's going to tell you a little more about his background. Dr. Micah has won dozens of Orange County Best Doctor Awards. He's been America's Best Oncologist Awards. He's won Teaching and National Research Awards. He is honored to be our first JCC Zoom medical event today. And I want to thank you and welcome you. And so we will get started now. Welcome, Dr. Micah. Micah.
Yeah, thank you, Jerry. So I'll just spend a minute telling you about myself. I think the first question here is for you to make sure I'm not a quack. So I think when you hear my background, hopefully you'll conclude I'm not a quack. But you know, I went to Reed College when I was 15 years old, skipped my last year of high school. From there, I went to Cornell Medical School in New York City. And Cornell's main hospital, New York Hospital, one of the biggest in the country. And then Sloan Kettering was our cancer hospital. After medical school there, I stayed on and did a 4-year OBGYN residency there and was invited to stay on the full-time faculty. And the year I was on the full-time faculty there at Cornell, I did a partial intensive fellowship at Sloan Kettering. Also, the head of gynecology, Stan Birnbaum, had a heart attack. So they made me acting director of gynecology at Cornell. I was only 29 years old and had 150 OBGYNs and 26 residents to ride herd on, but that worked out well. After that, the head of obstetrics had a little problem. He lost 6 mothers in short order, and the kind of patients sent to him. He needed 3 months off, so I became acting director of obstetrics at Cornell. And finally, we did some research there on toxic shock syndrome, which is hard to believe. In Manhattan, we had a baboon lab and were able to basically recreate toxic shock syndrome in baboons and figured out how tampons and certain bacteria cause toxic shock. From there, I went out to California, did a GYN oncology fellowship for 3 years. And GYN oncology, we'll talk about that in a minute. When I was done there, we were supposed to go back, my wife and I were supposed to go back to Manhattan to Cornell for me to be director of GYN oncology. My wife is a real New Yorker. We've been together since we were 15 years old, a really New Yorkish girl who always said we're going back to Manhattan, but walking down the beach in Newport one day, she said, you know, this isn't so bad here, maybe we should stay. So I hung a shingle up across from Hoag Hospital. And my practice there grew from just my little one-man practice to the busiest practice on the West Coast. So I had about 75,000 patients when I quit the practice last year after 34 years. And now I just have a small one-man practice and a research foundation that I help to run. Now, when I called JCC to check and make sure we were still on, you know, I figured with coronavirus you might be canceling. So I have to tell you, I got someone that sounded like my wife, somebody with a very strong New York accent answered, and she said, "Oh, what's your topic?" And I said, "Oh, living to 100 plus." She said, "Wow, you're sure an optimist." So I think you probably know who has answered the phone, but that was, we had a good discussion about living to 100 plus, and I think it was a good way to figure out that we were not going to have the meeting, we're going to do a Zoom meeting. So now to get on with what we were talking about in terms of living longer, I used to be a cancer surgeon, a cancer doctor, and just one last brief aside, G1 oncology, it was a subspecialty of obstetrics and gynecology. They created in 1974 because women with gynecologic cancers like cervix cancer, ovarian cancer, they were just too complicated for the usual medical specialties. Like a woman with cervix cancer, very quickly, within a few weeks, they would end up with 6 or 7 doctors. A gynecologist to biopsy the cervix cancer, a urologist to look in the bladder, see if that was involved. General surgeon to look in the rectum to see if that was involved. Medical oncologist to decide if chemotherapy would be useful. A radiation therapist to decide if radiation could be helpful, and a few other doctors. So it was really impossible to care for the patients. So they decided then we'll just take 35 doctors in all of the United States. We'll spend 17 years training them. And at the end of the day, when they're all done with their training, they'll be able to take care of these cancer patients from head to foot, do all the radical surgery, do the chemotherapy, do the research medicines, do pain control, and so on. So that's my background, this total patient care background for these complicated cancer patients. Since I quit doing that a year ago, I left my group. I'm basically doing the same thing now, but just general care, not specifically cancer care. I don't do surgery anymore. Now, as far as living past 100, it's very interesting when you look at lifespans. 110 is probably the limit of lifespans today if everything gets done optimally. I mean, with our current medical technology and with the current medications, probably about 110 is as far as you can go. The oldest person to date in the world lived to 122. But when you look at lifespans over history, it's pretty amazing. If you go back 30,000 years, if you go back to the ancient Greeks and Romans and Moses and King Solomon and so on, the lifespan back then was just 30 years old. And that stayed that way for thousands of years until about 1850, it went up to 38 years old. And basically in 1850, it sounds dumb, but a fellow named Semmelweis, a doctor, figured out that if doctors washed their hands before they delivered babies, the women were much less likely to die after, and this is with no gloves. If they washed their hands before they delivered babies, that they were much less likely to die after the delivery. And then shortly thereafter, the same conclusion came about with surgery. If you wash your hands before surgery, patients are less likely to die. So in about 1850, the lifespan went up to 38 years old from 30. 1900, it went up to 48 years old. Now, from here on out, a lot of this increased lifespan has nothing to do with doctors. Doctors would like to take credit for it. But in about 1900, it was really indoor plumbing. When indoor plumbing came in, the incidence of cholera and other infectious diseases went way down. And that, bumped up lifespan considerably. Then between 1900 and 2010, you go all the way from 48 years old, 48-year-old lifespan to 81 years old. And during that 100 years or so, we had a lot of advances. Antibiotics came on board, vaccinations for polio and so on came on board, measles. Intensive care units were developed. People stopped smoking recently, and then things like statins came on board. So I think, when you look at it, it's interesting to see how that lifespan really is just the last 150 years that the lifespan finally has really increased a lot. One of the advantages I have in terms of trying to get people to live to over 100 is that if you make it to, for example, 70, your lifespan goes up to 87. And if you make it to 80, you're most likely going to live to 90, which the insurance companies know this. That's why they're willing to sell you insurance. Maybe when you're 64 or something, you're surprised they're willing to sell you a 10-year life insurance policy. That's because they know that most likely you're going to live to be 85, 86, 87. So with the age group we're talking to today, I don't know our average age, but you're probably going to live to be 87 or 88 to start with. So we just need to get 13 more years out of you, and we're up to 100 now. As far as just starting out with some really practical things, it's amazing. This is so stupid, but avoiding falls and fractures is huge. 20% of people die within 6 months of a fall or a fracture. About, amazingly enough, 25% of my patients in the last 6 months have had fractures. And you know, the older you get, you know, we all know the multiple reasons that, you know, you can trip and fall, but you really have to child-proof your house. In this case, fall-proof your house for yourself, because your balance won't be as good and so on. But there are, you know, other things too, like medications. I think there's no question a lot of, you know, people as you get older, you have some trouble sleeping and whatnot. And you need to just be careful and, you know, have your doctor adjust your medicines. You can probably get by with a lot lower doses of certain things. Ambien, you know, Xanax, Restoril, Valium, Benadryl, narcotics, alcohol. Basically, you know, if those things are really, you know, something that is benefiting your lifestyle a lot, they're probably okay to use, but they have to be used carefully. And you're very likely to find you might need only 1/10 the dose that you used to take when you were younger. Your liver changes, your brain changes, and so on. But I think, you know, anything you can think of really to decrease the risk of falling is huge. Estrogen is, you know, a huge topic in terms of trying to get people to live better and live longer. And I think we mentioned at the end here, I have kind of a chart of special sauces. And, you know, doctors, I think, you know, many people might think all doctors prescribe the same medicines and have the same view of things. It's really not that way. Maybe 50% of medicine is scientific, 50% is art. I mean, there's not enough data to make a decision. And estrogen is a great example of that. I've got really good friends like Dr. John West, who's a great breast surgeon, John Links, a great breast medical oncologist. You know, all they do is breast cancer all day, and they tend to be against estrogen. But I think it's one of these situations with them. They're great doctors, but they're in this one little silo, and all they see is breast cancer issues. They are not able to look out, and there's maybe 1,000 different silos in medicine now. It's so specialized. But when you start looking at things like osteoporosis, estrogen is the best medicine for osteoporosis. You get almost an immediate, very rapid 4 to 6% increase in bone density taking estrogen, and you know, with really very few side effects. So I think in terms of things like decreasing fracture risk, and the fact that 20% of people are going to die if they break a hip or something like that, I think, you know, that's where I think it helps to have a doctor that's trying to take care of you from head to foot and not just one little part of you, because figuring out what's the, you know, overall benefits of, say, taking estrogen, preventing falls, preventing you from getting a spinal fracture and ending up in a wheelchair, or, you know, and so on. It's, you have to put all those things together. Estrogen too, so it does decrease fracture risk, there's no doubt about it. Vasomotor symptoms, and definitely decreases that. The genital urinary symptoms, urinary incontinence, pain with intercourse, decreases that. And in some patients, definitely will decrease anxiety, depression, and insomnia. So not in all people. About half of women don't need estrogen after menopause, and they don't have any symptoms. They almost certainly they're making their own estrogen is what they're doing. Their adrenal glands make estrogen precursors, gets converted in peripheral fat to estrogen, so they don't get osteoporosis, they don't have hot flashes. The other 50% though, definitely you know, need to be you know, taken seriously. You think about it, you know, men do not stop, their testosterone doesn't stop. I mean, men keep producing testosterone till the day they die, and for women to be cut off at 51 years old age from their estrogen is, you know, it's a big problem. And in the old days, when you died at 30, it didn't matter. But when you're going to live to be 100, try to keep your bones strong and your blood vessels strong. It's definitely something to think about. Oddly enough, when you start researching these different medications, and what I did about a year ago when I decided to leave the cancer practice and start my own little concierge practice, I wrote myself a nice little textbook, 300-page textbook. So going through all these issues and reading Harrison's 3,000-page textbook and so on and so forth. Amazingly enough, some of the things that you find in really researching estrogen is there is a decreased risk of colon cancer with it, and a decreased risk of rectal cancer, which I don't really, even as an oncologist, I have no idea why that is. I don't think it's clear, but it's very consistent in big estrogen studies. There are decreased risks of that. I think one of my partners told me not too long ago, I think he was up in Mammoth with his kids skiing, and they got passed by what looked like an old lady skiing down the hill, and they raced her down the hill and got to the bottom. She turned out to be 84 years old. And Mark, my partner, just looked at her and said, "You're on estrogen, aren't you?" And she said, "Yes, I'm taking a double dose." So here she is, 84 years old, skiing like crazy, very active. And I think, again, there's risk and benefits to any medications. But I think clearly there's a lot of benefits to estrogen, and it just has to be used properly and used with other medications that can reduce the side effects. Estrogen, as far as issues with estrogen, and breast cancer obviously is a big issue. Estrogen by itself does not cause breast cancer. And what you have is like 1,000 studies that will say, looking at issues like that. And maybe 20 will say there's some increased risk of breast cancer, and 980 will say there isn't an increased risk. And but if you look at animal studies as well as the big people studies, there isn't an increased risk. What estrogen will do if someone has a pre-existing breast cancer, estrogen positive breast cancer, it'll make it grow quicker. So it doesn't increase the overall risk of breast cancer. But if somebody had an estrogen positive breast cancer that was just starting out, it would make it grow quicker. And that is something that is dealt with through getting mammograms, for example. The other side of that story is that the estrogen, the breast cancers that have estrogen receptors are the slow growing types of breast cancers. They tend to, most breast cancers are there about 7 years before the doctors can feel them. So the mammograms pick it up during that 7-year period before you can even feel it. But the estrogen receptor positive breast cancers tend to be slow growing. And we hear a lot about breast cancer from Komen and so on. But amazingly enough, for stage 1 and stage 2 breast cancer, the 5-year cure rate is 100%. Now, that doesn't, what happens with breast cancer, there are people definitely, they recur after 5 years. So you can't just look at 5-year survival. But amazingly enough, breast cancer has a very high cure rate. All stages of breast cancer, taking all stages, stage 1, 2, 3, and 4, the cure rate is 5-year cure rate is 90%. So breast cancer is a very, treatable, curable disease if someone does get it. It's not like our patients with ovarian cancer. They have a 35% cure rate. It's hard to diagnose. It's hard to treat. So I think, at least as a GYN oncologist, I think, breast cancer is really quite an easy cancer to diagnose and to treat, and has very good outcomes. So it's not, as scary as pancreas cancer, ovarian cancer, and so on. I think, in general, though, with the breast cancer story, you just have to avoid kind of this one factor thinking. You need to look at 20 different issues when it comes to estrogen, and not just look at breast cancer by itself, estrogen and breast cancer by itself. When you put estrogen and progesterone together, that's different. There is an increased risk of breast cancer with that. And the progesterone in animals and in the big studies of people, that seems to be the hormone that can increase the risk of breast cancer. And that's basically used, that combination. If someone still has the uterus in place, they need the progesterone in addition to the estrogen. Whereas if the uterus is not in place, people can just take estrogen alone. But there are a whole series of treatments that people can take to decrease breast cancer risk. And amazingly enough, aspirin, when you, again, start studying all these different medications and diseases and looking at data, aspirin decreases breast cancer risk, diet decreases breast cancer risk, maintaining a healthy weight decreases breast cancer risk, and statins and a medication we'll talk about called Zetia, both lower medicines that lower cholesterol, those may decrease breast cancer risk. And of course, most importantly is just getting the mammograms so that they're picked up early and treatable. So I think, you know, the estrogen story, depending on which doctor you go to, you'll get a full spectrum of opinions. As a GYN oncologist, I can tell you, for example, all of our ovarian cancer patients that we treated, we put on estrogen if they were young. There's no evidence it changed their cure rates, but it certainly made them tolerate their surgeries and chemotherapy better because we had to take their ovaries out. So that's brief discussion of estrogen. Aspirin is another miracle drug. Now, aspirin, if they could come up with a drug today that does what aspirin does, it would be, you know, $50,000 a month. I mean, it's amazing what it does. Now, when you look at aging and inflammation, what happens when you get older, your chromosomes don't change. So when you're 100 years old, you have the same DNA, same chromosomes as when you were born. But what happens is the DNA kind of gets clogged up with proteins, so it doesn't work as well. And that's why these anti-inflammatory medications can help to prevent diseases and probably prevent aging too. The clogging up of the DNA so it doesn't function well is what probably causes a lot of aging. And I think when you look at what aspirin is, this is well established. I mean, a lot of studies on it. It definitely decreases the risk of heart attacks. And with heart attacks, it's important to know you can have a perfectly normal blood vessels. If you do an angiogram and vessels, say your heart blood vessels can look completely normal, and there can just be a little fine coating of cholesterol on the blood vessels, and you can't even see it. But if it cracks, you'll get a clot in it, and that clot is what will form the heart attack. That will, and literally you can die from that. So things like aspirin, they reduce inflammation, and it prevents clotting. It reduces clotting. So that's why if you're on aspirin and you're shaving, you cut yourself, you notice you bleed for a couple minutes instead of clotting right away. But the aspirin, and as far as your blood vessels, it reduces inflammation. And a lot of hardening the arteries, again, it's an inflammatory process that's causing the cholesterol to settle on the blood vessel. So by reducing the inflammatory process, you get less cholesterol settling there. And then if you do get a little crack in your cholesterol, you're less likely to form a clot and have a heart attack. It's the same thing with strokes. 90% of strokes are due to clots. They're thrombotic strokes. They're not bleeding. They're not aneurysms that blow out. So taking aspirin also decreases the risk of strokes because 90% are due to blood clots. Aspirin decreases your risk of heart disease, hardening of the arteries, decreases your risk of blood clots too. So if you're on a plane and you're worried about blood clots, that's the sort of thing. It's very easy to visualize. The aspirin makes your platelets not work as well, and you don't clot as well. You actually want to bleed a little bit easier when you're on aspirin, but reducing the risk of blood clots that's important. And again, going through literature on aspirin in different diseases, it actually decreases your risk of diabetes. Now, who would think? But diabetes is largely, it's an autoimmune disease. It's an inflammatory disease. Your body is attacking your pancreas. And I think by reducing inflammation, aspirin kind of tones down your immune system. That's probably why it reduces your risk of diabetes. And oddly enough, aspirin also reduces your risk of breast cancer. So I think, and these are big studies. I mean, like 100,000 nurses in Boston and so on. I mean, they're not some little, anecdotal studies. So, and when you're starting to look at things like, okay, can I take estrogen? It can increase your risk of clotting, or it could increase the risk you're worried about breast cancer. You look for other things like this, the aspirin, that could decrease your risk of clotting, decrease your risk of breast cancer. And all people need is the baby aspirin, the 81 milligram, the enteric-coated aspirins, the ones that are less likely to irritate your stomach. And now some people will say older people shouldn't take this. If you're 85 years old, you might fall down and get a black and blue mark. And I don't know, I just don't buy that. I mean, if you're going to live to be 100, I think you might have to live with a few black and blue marks. But if you could prevent a stroke or a heart attack, things like that, it's worth putting up with a few black and blue marks. Statins are another thing in terms of trying to live as long as possible and as well as possible. The British Health Service basically would like to put statins, Lipitor, Mevacor, and so on. They would like to just put it in the water systems in England. I mean, which is kind of amazing. I mean, the British health system is always kind of in favor of minimal care in a lot of ways, but statins are so cheap and they're so obviously beneficial that when you read the recommendations coming out of the National Health Service in Britain, they would like basically everybody to be on a statin. It does, the newer data too is that the lower the cholesterol, the better. So many people used to say, oh, less than 250, less than 200. Or really, the bottom line is, as more and more data has accumulated, the lower the cholesterol, the better. So you might say, well, cholesterol is only 20. Well, it would be better if it was 150. And 150 really be better if it was 120. I mean, in terms of trying to make it past 100. So the statins, there are tons of studies now over decades, definitely decrease the risk of heart attacks, decreases the risk of strokes, decreases the risk of hardening of the arteries, decreases the risk of blood clots, thromboembolism, and again, it decreases the risk of diabetes. Now, exactly how it decreases the risk of diabetes, I don't know. I'm not sure that's well known. I have to study that some more, but it's definitely there in big studies. And there, again, is suggestions that it decreases the risk of breast cancer, statins do. So I don't know, again, that's kind of a plus minus, that's not definite, but it's interesting to see that. So all the statins are equivalent, so it doesn't matter if you're on Lipitor or Crestor or whatever. If you don't tolerate one, it's definitely worthwhile trying another. But basically, it's Pepsi versus Coke. When you see them advertising on TV, this one's better than that one, it's not true. It's Pepsi versus Coke, and all the statins lower the cholesterol the same amounts and are equally effective. If your insurance company says you have to take Lipitor first, you just take it. And then if you don't tolerate it, then you can take a different statin. Zetia, Z-E-T-I-A, and that's another really amazing medicine. Basically the same story as statins in terms of lowering cholesterol. But rather than working through your liver, the way statins works through your liver to decrease cholesterol production, it just keeps the cholesterol in your GI tract. So you eat your 2 eggs with breakfast. The Zetia is a tiny little pill. It keeps the cholesterol going right, through your stomach, through your small bowel, through the colon, and out in the toilet. So you don't absorb the cholesterol in the first place. So it's a totally different way. It works really well in about 10% of people, but it works in a lot of people well, but extremely well. Like you might see a cholesterol go from 250 to 100 with Zetia in about 10% of patients. But it's a very simple medicine to take, and I think that's certainly something to think about. And just like with the statins, the data is there. It decreases heart attacks, decreases strokes, decreases hardening the arteries, decreases the risk of blood clots. Again, it decreases the risk of diabetes in these big studies. And exactly, the mechanisms are, you'd have to get into that. And also, there's that plus minus decreased risk of breast cancer. So, cholesterol it's a building block for progesterone, for estrogen, for a lot of steroids. So it may be that that's the mechanism where statins or Zetia could decrease the risk of breast cancer if it decreases your internal production of things like progesterone. But good old fish oil, Here's our old fish oil. That basically has the same activities or effects as statins and aspirin, but it's just not as strong. So it's a it lowers the risk of heart attacks and strokes, hardening of the arteries, blood clots, and even diabetes. But it's maybe a third as effective, say, as actually taking these other medicines, or a quarter as effective. But it's very simple to take. You do want to actually bleed a little extra. So you'll notice the fish oil does have some anticoagulant effect, and you will bruise more easily. Or again, if you're shaving, you'll notice you bleed for 5 minutes instead of 30 seconds, but that is actually what you want. You want your blood a little thinned out. So if you start to get a clot in your coronary artery or your brain, it doesn't form. As far as diet goes, obesity is very well established. It decreases lifespan 6 to 10 years. So, it's not just a cosmetic thing. When people are obese, they will live 6 to 10 years longer. So the idea of healthy weight it's not just a cosmetic thing. I mean, and I really feel sorry. I clearly, some people that are very obese, there are, undiscovered, I think, hormonal issues and genetic issues, things that we haven't figured out yet that really make it very, very hard for them to control their weight. But it's certainly, something that really has to be taken seriously. It's not just a cosmetic thing. So diet, a good diet, definitely same story. It does decrease the risk of heart attacks, strokes, hardening the arteries, clots, diabetes, breast cancer, uterine cancer. Alzheimer's is plus minus. I mean, there's really no medicines or no diet that seems to clearly prevent or decrease the risk of Alzheimer's. Now, diet might have some influence, but it's really not clear. As far as healthy diets, basically it's moderation. Sugar is as bad as fat, so I think you really got to watch the sugar. And with some estimates are up to half of Americans have diabetes or hyperglycemia, and that will damage your blood vessels, your kidneys, your heart as much as fat. So in a lot of ways, you might be better off having a little cheese for dessert than having a nice ice cream sundae. But I think that watching the sugar as well as the fat. The Mediterranean diet's a very healthy diet, with your fat from olive oils and avocados and things. But, Japanese diets, there's plenty of healthy diets, and basically in moderation and going easy on the sugar, I think it is a key to a lot of the diets. As far as exercise, I'm not a big exercise person, and for years I thought it was just a jock thing. I mean, my friends who like exercise were getting their endorphin rushes from exercising, but it really is medically beneficial. I mean, it's not just a jock thing, and I think they're having their own set of problems. My friends who are jocks are blowing out their knees and their hips and so on, but there is a decreased risk of, and there's good medical biochemical reasons for this. Exercise does decrease your risk of heart attacks and strokes, hardening of the arteries, decreases the risk of osteoporosis. That gravity, weight bearing is important for preventing osteoporosis. Exercise does decrease the risk of blood clots and actually breast cancer, uterine cancer. Does decrease the risk of depression and anxiety and insomnia. So there are a lot of benefits to exercise as you get older. Fortunately, a lot of this exercise does not have to be very vigorous. I mean, a 20-minute walk for an 80-year-old or 85-year-old is probably 20-minute walk a day is probably, you're going to get most of the benefits out of it. You don't have to be Superman, but I think, part of the exercise story, of course, is healthy weight. I mean, people that tend to exercise will have healthier weights. And psychologically, it's interesting to me that exercise, does help depression, anxiety. You think about endorphins. You think also about people like, Sigmund Freud. I mean, Freud says the best treatment for depression is move forward. You just move forward. And I think, walking forward, it makes you feel like you're getting somewhere in life, whether you are or not. It's an important, psychologically, it's good to get out and walk and exercise some. We're getting near the end here. Immunizations are huge. I mean, when you start talking, you start looking at those lifespans that I discussed. I mean, going from a 40 years old lifespan in 1900 to 81 today, or even older, a lot of that is vaccinations. And children are great. The pediatricians are great at getting kids vaccinated. I mean, the childhood vaccines are almost 100% compliance with those. Adults, we're not so good at. Maybe 50% of adults actually get the vaccines they should get. And I think that there are actually cancers you can prevent with vaccines. Cervix cancer can be prevented with vaccines. The human papillomavirus, HPV, giving that to your 12 or 13-year-old, both your daughter and sons, will prevent cervix cancer and also other cancers, head and neck cancers. So, but in terms of, most relevant to our age groups, getting, vaccinated will decrease your risk of pneumonia. Just one injection with, two injections with the pneumonia vaccines. There's two separate pneumonia vaccines. One covers 13 types of pneumonia bacteria, another covers 23 types. So if we add them up, you've got 36 types of pneumonia bacteria covered, and it's a lifelong protection. So getting those pneumonia vaccines is very worthwhile. The flu vaccine every year, it's about 70% effective in preventing the flu. And you can see with all this coronavirus scare that, the flu is a big deal when you get older. When you're younger, not such a big deal, but you start getting older, having other medical problems, getting the flu vaccine is very important. Shingles, it's hard to believe up to a third of people get shingles. There are good shingles vaccines out now. You have to get 2 doses of it, 2 to 6 months apart, and that does give you lifelong protection. Some of the other things you wouldn't think about, like the tetanus, diphtheria, pertussis vaccine, you think that's more for kids, and it is for kids, but adults ideally should get it every 10 years. And the reason really is not to protect you, but to protect your grandchildren. The most common source for children getting pertussis, for example, whooping cough, is the grandparents, and that's well established. So, when you're getting your DPT vaccine at Costco or whatever, it's not uncomfortable for you, but it really, and you won't get whooping cough most likely, but you're the main source for your grandchildren getting it. Things like hepatitis A, and in our age group, generally, hepatitis vaccines are not really necessary. We're not doing intravenous drugs and having lots of, dangerous casual sex and other sources of hepatitis. So I think if people want to get a hepatitis vaccine, hepatitis A, fine, but it really is mostly designed for younger people. And, even the babies now are getting a hepatitis vaccine. So to summarize here, the keys to making it to 100 plus, number one, avoid falls and fractures. And like I said, many different causes, the obvious things. I've got an old patient out here on Balboa Island. She's got a 70-year-old shag rug in her house still, and trying to talk her to give up her shag rug. She's 90 years old. It's very hard. She should get rid of her shag rug. But I think, a lot of it, probably the things you can really do is, watch the alcohol intake. If you're going to take Ambien or Xanax or something, break it down, see how little you can take. You may find you could take 1/8 of a pill and get the same effect, because you get up at 3 a.m. to go to the bathroom and, you're zonked out on Ambien or something, you're much more likely to, trip or hit your hand on the door and break it, and so on. And then I think, estrogen, aspirin, statins, Zetia, those are all, excellent things to take if there's no contraindications. So obviously, if you have an estrogen positive breast cancer, you shouldn't take estrogen. If you have a bleeding ulcer, you shouldn't take aspirin, and so on. But if there's no contraindications, those are definitely worth thinking about. Getting your immunizations is important. Not smoking is important. Using alcohol sparingly, exercising, the diet, Mediterranean diet or whatever, just eating in moderation though, maintaining a healthy weight. And glycemic index is important. Glycemic index, if you look it up on the internet, it basically tells you how much your blood sugar is going to rise if you eat a certain food. And that is, it's very important. It's surprising what foods will just boost your sugar way up. It's not just Coca-Cola. And I think that's something that's easy to look up. And then, finally, as far as making it to 100, having a good doctor is important. I mean, it's really, I think, some people just sort of give up once somebody's 80 or 85 and they start backing off on mammograms. You don't need them as often, but depending on your family history, I think, just having a doctor who's not over aggressive, but also that just doesn't start, reducing care automatically. As far as, I have my little secret sauce chart there that some of you got a copy of, and that's at the end of my textbook here. This is my draft of the textbook here, and I haven't bothered to actually, I think I'll just keep in that form for now. But this here, again, I know you can't see this, and that's one problem with Zoom, but basically it has all these diseases on the left side, diseases and symptoms, about 15 of those, and then different medications across the top, and immunization, exercise. You end up having to put that whole picture together to figure out what's best for the individual patient. So that's where the secret sauces come in. It's not, you really do have to individualize these things and figure out, what people can tolerate, what they can't, how aggressive they want to be, and so on. Finally, this is just a little silly thing I did, but I know Don Abrams, he's an excellent gastroenterologist. We loved working with him for 35 years now. We sent our most complicated radiation bowel damage patients to him and so on. But Don had a nice little handout, one-page handout for managing constipation and loose stools. And I looked at that, and when someone has trouble with their bowels, constipation, whatever, they'll be told, oh, take some more fiber or take some Metamucil. It's too nonspecific. So being an overachiever, I actually went and created this little, for one of my patients, I call it GI Comfort. And it's about a 10-page little handout. It goes through actually how much fiber is in all the different foods. And if someone's going to take Metamucil, how they should take it, and then how they back off of it, and how you replace the Metamucil with fiber from foods so you can reduce it. And if that doesn't work, different laxative regimens, because you don't need a doctor for most of this. If you just have a nice little recipe book, you can do, manage your own, these kind of uncomfortable bowel issues yourself. So if people would like a copy of that, it's not going to probably make you live longer, but it might make you live a little more comfortable. And I think we'd be happy to give that to people. It costs us $5 to print these, but we're happy to give them to you. Or if you want to make a donation to Women's Cancer Research Foundation, that's our 501(c) nonprofit foundation, give $10 to that, if you want to feel like you paid something for it. But I think it's a nice, simple, practical thing that you can, take care of yourself at home, because everybody does get bowel upset now and then. So I think that's about it. I think if I'll leave it up to Jerry to take it.
So now I'm going to manage the questions. And if you have a question, please just write it in the chat at the bottom and I'll read them off. If you have trouble doing the chat, then just wave and we'll call on you and unmute you. So there is a question in the chat waiting. And so what are your thoughts on metformin and its side effects?
Metformin?
Metformin, yes.
Yeah, no, metformin's an amazing medicine. And it really, I think if people can tolerate it, it's the first line treatment for for type 2 diabetes. Amazingly enough, we actually did a cancer study on it, because ovarian cancer trial, because there is data showing diabetics for some reason have a better cancer cure rates, and the theory was the metformin might have been a factor in that, but our study with metformin and cancer treatment didn't show a benefit. But no, it's a terrific medicine. It's another one of those, like aspirin, where it's very inexpensive, and therefore you don't hear much about it. But I think that if they could charge $1,000 a month, you'd see it on TV advertised regularly. The biggest problem with it is just GI problems, people not tolerating the side effects. But if people can tolerate it, it definitely can, help to prevent people from getting type 2 diabetes requiring insulin or requiring other treatments for diabetes. So I think, it's an excellent drug if you tolerate it well. But if you don't tolerate it, with diabetes, there's a list of 20 good drugs, and you just basically go down the line, try one after another until you find one that you tolerate. And I think, that's it. But it's a very good medicine if you tolerate it well.
Okay, I'm going to unmute Deborah Hastings, and she says she needs clarification. Let's just keep it to maybe 2 questions, because I have a lot of questions lined up here.
I know. Can you hear me?
Yes.
Yeah.
Okay, I just wanted to make sure I understand a few things. That drug you mentioned, Zetia, Zetia?
Yes.
Okay.
Zetia.
You also said, I want to understand this. You said you need to take estrogen and progesterone together if you still have your uterus?
The estrogen alone can cause a uterine cancer, and it's a low-grade cancer, but it can cause uterine cancer. Estrogen, it's interesting. The studies doesn't show an increased risk of breast cancer, but we know there's an increased risk of uterine cancers. They tend to be these low-grade, very curable uterine cancers, but because of that, you have to take the estrogen. Kind of stimulates the uterine lining for the first 2 weeks of a woman's cycle. And the progesterone comes along and turns off the uterine lining, so that's when people have their period. So you end up having to take both in some form or another. If you're going to take the estrogen, so that's where that comes from. There's different ways to take the progesterone so people don't have their period and all. You don't have to go through that. There are other ways to take it.
The other thing was, we were going to take baby aspirin, and my husband looked at the side effects and said that it was more dangerous to take it than not.
Yeah, well, I think that's true of practically every medication. If you read the side effects, my God, you'll never take anything. Water, you could drown in water, but I think, I think in elderly patients, there'll be some controversy. Some people will say, the risk of falling and bleeding and so on is greater. But I think, to me, I'd be much more worried about having a stroke or a heart attack. And I think the main side effects would be, you look at GI bleeding. Could it cause a stomach ulcer and bleeding? Stomach ulcers, when I was 35 years ago, every day people had surgeries in the operating room to take out ulcers in their stomach that were bleeding. With the advent of Pepcid, Prevacid, those sort of things, you just don't see bleeding ulcers being a problem like that anymore. So I think if you take the baby aspirin, and it's the enteric coated, so it actually gets through your stomach into your small bowel where it's absorbed, it really should be very safe. And but you're right, there's risk to everything, and we're basically trying to defeat nature here. And natural history here is we'd all die at around 40, but I think when you try to defeat nature, there's going to be some side effects with the treatments.
Thank you.
Thank you. Okay, I'm going to go to the next question. There was quite a few lined up here. Let me see. Okay, what are the side effects of Lipitor?
Well, the Lipitor, mostly people get some muscle aches and pains, and and they can get some muscle weakness with it. In 99% of the time, that's annoying, but it's not dangerous. So if someone gets the muscle weakness or muscle aches and pains, you can either lower the dose or try a different statin. And oddly enough, although the statins all lower cholesterol equally, you will have patients, you can switch from Lipitor and they're having muscle pains over to Crestor and they don't have the muscle pains. But maybe very rarely, maybe 1 in 1,000 patients, the muscles can actually start to dissolve. And it's called rhabdomyolysis. And that's serious. The muscles start to dissolve. The byproducts of that can cause kidney failure. I just had one patient in my life that had that. And, she turned out to be fine. We had to just take her off it and be patient. Everything got better. But I think overall, the side effects are very rare and not serious, but the doctors know, to look for those 1 in 1,000 patients where they have rhabdomyolysis, that muscle dissolving problem, and don't give them the Lipitor, don't give them statins. But again, you wouldn't have the British Health Service, and I think pretty much the American medical system too, recommending you put statin in the water if it was very dangerous stuff. But if people do have muscle pains, you need to let the doctors know. You can do a blood test to see if the muscles are dissolving. I mean, there's enzymes from the muscle that show up in your blood test. And they say, okay, it's nothing. You just have sore muscles, versus you're the 1 in 1,000 where the muscles are kind of dissolving with this stuff.
Okay, the next question is there a test to determine if you're still producing estrogen to decide if you should add estrogen and how much?
No, not really. I mean, estrogen, it turns out it all comes back to basically the brain, and people having probably different estrogen receptors in their brain and so on. So you can have somebody that you really just have to base it on symptoms. I mean, if someone has no hot flashes and no osteoporosis, they don't need estrogen. And also no, say, pain with intercourse or something, they don't need estrogen. They're in the 50% group that doesn't need it. But in terms of the other group, if they're having hot flashes, if they have osteoporosis, the checking estrogen levels doesn't help. I mean, you could have somebody with very low estrogen levels, they have no hot flashes. You could have somebody with high estrogen levels and they're miserable, and they even need it higher. I mean, their brain receptors for estrogen are set differently. They're not going to be able to sleep. They're going to be anxious. They're going to be depressed. And you put on 2 estrogen patches instead of 1, and sure enough, they're like a new person. So I think it's, the estrogen, it's different when, with the infertility docs or something where they're trying to time ovulation, they follow hormone levels very carefully. That's a whole different ballgame. But in terms of postmenopausal estrogen replacement therapy, it's not useful to follow those levels. And there are a lot of, there are doctors that make practically a whole living out of, fine tuning estrogen and drawing all these blood levels. But I do think really it's making something very complicated that isn't. And the estrogen too, it's almost all estradiol. So you hear, oh, natural estrogen versus synthetic versus this and that. It's really it's the same chemical, estradiol, in virtually all the estrogens. And the one exception is Premarin. Premarin is made from horse urine. And I think it has about 34 different types of estrogen in Premarin. And the main ones are estrone and estradiol. But Merck has been amazing. They've been able to continue to charge a fortune for Premarin because you can't break a patent on horse urine estrogen. I mean, it's so variable. But in general, if you're paying extra for Premarin, they should just switch you over to the generic estradiol. And the reason Premarin is so expensive is not that it's better, it's just that nobody's been able to break Merck's patent on it. Okay.
Yeah, there's other questions along the same lines. an HRT regimen is prescribed, do you recommend intermittent checks of hormone levels?
No, it's just a symptomatic thing. I mean, really what we want to check is things like your bone density, your osteoporosis checks. I mean, every 3 years, is the estrogen making your bones stronger? That's the key variable there. So, but basically, if people are comfortable with the estrogen, if they're not having hot flashes, if they're able to, function normally, then that's the right amount of estrogen. Unless we see, say their bone density is not increasing enough, you might say, okay, let's go to a little higher dose of estrogen to try to strengthen your bones some more. But yeah, again, I don't know I'm trying to think what it's comparable to. I guess maybe, probably in psychiatry. I don't know psychiatry that well, but my guess is if someone's on an antidepressant, say Lexapro, I don't think the psychiatrist check blood levels. What they'll say is, are you depressed? And do you feel better? And if not, they give you some extra Lexapro. See what I mean? Because everybody's brain is different when it comes to Lexapro or antidepressants. And I think estrogen, I would look at the same way. It's not a blood level thing. It's not like checking your blood count to see if you're anemic or what's your blood sugar level. It has too much to do with the brain and brain receptors and all for the blood test to be too useful. If you could do brain biopsies, Jerry, that might be worthwhile. But I wouldn't suggest it.
Okay. I don't see any other questions in the chat, and I don't know if people who don't have their video on have any questions. You could unmute yourself and speak if you like. Otherwise, we will conclude. So any other questions? Deborah, you have another question. Okay, hold on.
Now that I'm allowed to have another one.
Yes.
So in regard to mammograms, it used to be that if you reached a certain age, you wouldn't have any more. From what I'm hearing you say, it doesn't really hurt to keep having one.
Well, the only thing that hurts probably is your pocketbook, because Medicare or insurance companies may not want to pay for it. But I think, if people have, a strong family history, I mean, I have patients where, 5 first-degree blood relatives have had breast cancer, they should keep getting it every year. Somebody with no family history, no one's had breast cancer. Yeah, I think it would be, I think the literature there, since a breast cancer takes 7 years to develop, on average, I suppose if you're 93, you could say, well, you'll be 100 before you get a breast cancer. Maybe we'll cut back on the 93-year-olds. But no, I think, some of these things are important psychologically, if nothing else. I mean, a lot of the patients, I think maybe every 3 to 5 years would want a mammogram just so they don't worry about breast cancer as much. But I think, I wouldn't say everybody should stop at, again, I suspect something like the British Health Service says stop at 70, but I don't, I think that's not individualized medicine, and there are a lot of other issues that people have to deal with, and a lot of anxiety. It's amazing how much anxiety you can get rid of with a blood test or a sonogram or something sometimes. And I think if people are worried about breast cancer and they're on estrogen, do a mammogram, and then they can feel assured that they're fine. So,
thank you.
Okay.
This is going to be the last question. Is Zetia taken along with a statin? Wait, is Zetia taking along with statin, or is it one or the other?
Well, it used to be the insurance companies used to say you had to take the statin first and kind of fail that to add the Zetia. In other words, the cholesterol wouldn't come down enough. I think recently they seem to be more flexible. I mean, there's enough data on Zetia by itself now to show it's beneficial. But I think in general, people will be on the statin first, and then you add the Zetia to it. So maybe the statin brings your cholesterol down 50 points, the Zetia brings it down another 50 or something. It's that sort of thing. So I think, and I know at least in terms of different insurance companies or Medicare, if we do it that way, there's no fighting. If we tried the Zetia first, we might get a rejection, and end up with somebody getting a couple $100 bill that they shouldn't, they weren't expecting. But I think, yeah, so that's kind of the latest. If someone didn't tolerate statins, then Zetia for sure by itself would be a good idea. If someone had too much muscle aches and pains, for example, with the Zetia, it's rare, but maybe 10% of people will say, I just can't stand these statins. I'm sore all the time and it makes me feel old or something because of the soreness. Then yeah, they could just take the Zetia alone, and we would write in the chart, patient doesn't tolerate statins, and we wouldn't have an argument with the Medicare or the insurance company. So okay, so
Okay.
well, yeah, this was great.
This was great, and I really appreciate it. This was very informative, and thank you all for joining us. And I don't know if you want to give us information on how anybody here could contact you if they wanted to contact you, where your office is or anything like that.
May I have a question?
Yeah.
Who is
Oh,
that?
yes.
So I have a question less off the topic to Jerry. Do you have closed caption? So sometimes I miss some closed caption there.
I have to find out.
Yeah, because
I don't know.
with my hearing aid, yeah.
I will ask.
Because I tried to just turn it on, but I couldn't do this. But sometimes I miss some
I'm
part of
sorry.
conversation.
I'll find out, Rena.
Okay. Okay. Thank you, Jerry.
So Dr. Mika's assistant, Michelle, thank you also for helping practice this and set it up. We're always doing these things, practicing with people on Zoom, and everybody's Zooming these days. So Michelle, would you like to tell us if anybody would like to contact Dr. Mika?
If anybody's interested in contacting us, I guess you can email at drmika.com. Okay. Yeah.
Great.
And the name is spelled Dr. Mika, MICHA.com. You can certainly call at 949-418-5566. And we're located in Newport Beach.
Okay. Well, thank you so much, Michelle.
Okay.
Thank you again to Dr. Mika. And thank you all for joining us. And we'll see you at the next Zoom. Bye.
Bye.
Thank you.